Uh, Good afternoon, everyone. I welcome all of you to this webinar today. So, the topic is impact of multidisciplinary tumor board on cancer care. So, this is the topic that was mainly intended to discuss how the tumor board decisions are helping in improving the cancer care. So, I have with us Dr. Bhavna Sirohi, the Medical Director and Senior Medical Oncologist from Balco Medical Center. I welcome you, ma'am. Dr. Shalaka Joshi, she is Professor and Consultant Surgeon, TMH Mumbai. Dr. Tabsam Vatsadwala, she is Professor and Consultant from Radiation Oncology, TMH Mumbai. I welcome both of you to this webinar. Then we have Dr. Purvi Haria, Assistant Professor of Radiology, TMH Mumbai, and Dr. Ayushi Sahai, Professor of Pathology, TMH Mumbai. I welcome both of you to this webinar. And I welcome all the doctors of Dibrugarh Cancer Center. Please have a very nice discussion. We will start presenting the cases wherein you can have the discussions through and through. So just to give an outline of background about Navya. Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plans. We are working with the state government hospitals, and one of such event is happening at the Dibrugarh Cancer Center. We are working with Dibrugarh Cancer Center. I thank them for all the support that they are giving us in our work there. Dr. Bhavna Sirohi, all of you know her very well with 25 plus years of experience. She chairs various cancer committees for ACMR. She is instrumental in setting up new cancer centers across the country, has published 100 plus papers and edited 3 books. And she is the founder president of New India Cancer Charity Initiative that works on cancer awareness and screening in rural India. I welcome you, ma'am. Dr. Shalaka Joshi has 15 plus experience in oncology, surgical oncology. She is trained at TMH Mumbai in surgical oncology and King's College London on translation and cancer research. She has worked on a lot of clinical trials and translation studies as principal investigator. She was our principal investigator for key investigator for the patient preference tool, which was jointly developed by Navya Network to help empowered women to choose between breast conservative surgery and mastectomy. So that tool was conducted, RCT was conducted under Dr. Joshi's guidance. And she has presented various research papers at national and international conferences and published 80 plus research articles in various journals. I welcome you, ma'am. Dr. Tabsam Vatsadwala, she has 15 plus experience in the field of radiation oncology. She has contributed to the development of TMC's guideline on for modern radiation oncology practice. She is a member of various national and international oncology associations and has published more than 100 research articles in various journals. Dr. Ayushi Sahai, she is professor of pathology. She has 15 plus years of experience as oncopathologist. So she, after that, 10 years as specialist neuropathologist and 2 years as specialist breast pathologist. Special interests include brain metastasis, adult diffuse gliomas, pediatric high-grade gliomas, and meningiomas. She has 80 plus publications in various peer-reviewed national and international journals. She is recipient of several national awards. I welcome you to this webinar, ma'am. Dr. Purvi Haria has 10 plus years of experience in radiology, has fellowship in breast imaging from SGH Singapore. She is a member of several national and international radiology association and has published 15 plus research articles. And I welcome the doctors from Dibrugarh Cancer Center for a very fruitful discussion. I hope it will be a nice webinar. I welcome all of you, and we will start with the case presentation. I request our analyst to present the case.
Good afternoon, everyone. Am I audible? Okay. So our first case is a 57-year-old female with a known history of chewing tobacco and pan presented with complaints of vomiting, loss of appetite in February 2024, USG bilateral breast showed 2.2 into 2 centimeter left breast inner quadrant, 8 o'clock position lesion, 3.5 into 1.7 centimeter left mid axillary lymph node, February 16, 2024. On February 19th, core biopsy of the left breast showed invasive ductal carcinoma of no special type, cancer grade 2, and MRBS score 7. Pathology note, no lymphovascular invasion or perineural invasion, no DCIS. CT chest abdomen pelvis on February 27th showed 2.5 into 2.2 into 1.8 centimeter left breast upper outer quadrant lesion suggestive of neoplastic etiology, left breast skin thickening, few left axillary lymph nodes, largest 3.5 into 2.4 centimeter lymph node, 7 into 1.4 centimeter gastric antrum, distal body of the stomach thickening, 5.5 into 5.3 centimeter right adnexal lesion, suspicious for right hemorrhagic ovarian cyst versus endometrioma, and few subcentimetric locoregional lymph nodes, few mesenteric lymph nodes were noted. Radiology note, left breast upper outer quadrant lesion suggestive of neoplastic etiology, TNM stage T2, N2A, M0, WHO stage 3. Endoscopy on February 27th showed 3 into 3 centimeter irregular growth margins with incisure angularis, antral lesion. Pathology note, query malignant gastric ulcer. Diagnosis of endoscopic biopsy from stomach lesion showed adenocarcinoma of grade 2. IHC was negative for ER, GATA3, and HER2. Further, FDG PET-CT on March 5th, 2024 showed 2.5 into 2.4 into 2.1 centimeter left breast upper outer quadrant lesion with an SUV of 10.9, 0.3 centimeter breast thickness, left axillary lymph node, largest measuring 2.9 into 2.6 into 2 centimeter with an SUV of 7.1, 7.7 into 0.2 centimeter stomach distal body antral circumferential thickening with an SUV of 6.9, few subcentimetric left gastric lymph nodes, query reactive, left liver lobe lesion with an SUV of 3.3, query significance, 1.3 into 1 centimeter liver lesion, benign cyst, and no evidence of malignancy elsewhere. Radiology note, left breast hypermetabolic lesion, left axillary lymphadenopathy metastatic, stomach antral lesion metastatic. Malignant. Clinical TNM stage of breast is stage 3A, T2, N2, M0, and clinical TNM stage of gastric lesion, stage 1, query T1A, N0, M0. CBC on March 8, 2024, HP was low, 7.8, WBC also low, 3070, and RBC was also low, 3.13. Functional ECOG score of the patient was 2, able to do activities of daily living without any assistance. Symptoms include lump and occasional pain in the breast, weakness and fatigue. Questions are role of ERPR HER2 in the breast tissue, role of mastectomy versus neoadjuvant chemotherapy followed by surgery versus alternate, and role of resection of gastric tumor.
So I welcome Dr. Sirohi. Can you start the discussion, please?
So we have a patient with 2 curative primaries. One is stage 3 and one is stage 1. So I think ERPR HER2 is very important because if, whatever the receptor status, the patient would, neoadjuvant chemotherapy is indicated here for breast cancer. And some of the chemotherapies that we give in breast cancer, which is anthracycline and taxane, both of them are active in stomach cancer also. So the neoadjuvant regimen for stomach cancer includes anthracycline and taxane as well. So that would be my thinking, that we would wait for ERPR HER2 show, but consider the patient for neoadjuvant chemo followed by surgery. And maybe Shalaka can discuss whether upfront surgery for both the primaries also remains an option in some patients.
Dr. Sirohi, this is Dr. Ayushi. May I add some inputs here?
Yeah.
Yes, of course.
So
Yeah.
actually, as we can see from the biopsy reports, the gastric ulcer
You can
very
open
rightly
the
they have ruled out
biopsy.
metastasis from the
From the
breast
breast cancer, yes, yes.
GR-GATA3 HER2. But
Yeah.
they haven't ruled out the opposite. The GI metastasizing to the breast, since it's a synchronous presentation, and that can also occur.
Yes, yes,
So,
absolutely.
so not just ERPR HER2, we need to confirm first whether the breast biopsy is, because the way the BR scoring is 2 + 2 + 3, that means there is tubular or glandular differentiation, but the mitotic activity is very high. And they
Yeah.
have described 18 to 20
There is no
mitosis.
sound.
So
You're mute.
is
Yes, sir.
Yeah, now you can hear. It's okay.
yeah. Okay, am I audible now?
Yes.
Yes, ma'am.
Yeah. So if you see the BR scoring, they have given 2 + 2 + 3. That means there is 2 for the tubule. That means there is nice glandular differentiation, but the mitotic activity is very high, which is not in keeping with a grade 2 type of IBC. And then in that case, that would fit in with the metastasis of the moderately differentiated tumor in the stomach to the breast. Now we have our own series in which we have seen that, the metastasis to the breast from a lot of different sites in the body, most common being metastasis from the gynae, ovary or endometrium to the breast. But the second most common is metastasis from the GI to the breast. That it is a rare occurrence compared to the reverse, but it does happen. And in this case, being synchronous, I think we should rule that out also, because that will change your management drastically.
Yeah. And unless it is, a different ER pathology, if it is ER positive or
Yes, of course,
then
of
it
course.
would, then
Yes.
it would.
So first of all, GATA3 in the breast lesion also, and if the CDX2 or any other GI markers available, along with ERPR HER2 have to be done, and it has to be confirmed that it is a GATA3 positive tumor in the breast, and then what is the biomarker profile?
And CK7 will be positive both
In
for
both,
breast and
in
stomach.
both. Yeah, in
Yeah,
both. So
yeah.
that will not help. But GATA3, you can get focal GATA3 sometimes in stomach also. So that is why the whole panel of GATA3 as well as the CDX2 would be required. And a kind of, the pattern of positivity will also have to be checked, because morphology wise, and since you also see in the biopsy, there is no DCIS. Now that could be due to limited sampling, but if it was present, it would tell me that it is, there is a second primary from the breast, because there is in situ tumor also.
But if Dr. Ayushi, if ERPR HER2, I feel should be done first, because if
Along
HER2 is
or
positive, then it's unlikely with the stomach primary being ER negative, unless it's a lobular cancer where stomach primary could also be ER positive.
I think it could be done along with, these are not very difficult markers to get hold of. They have done already the GATA3, so they do have it, I assume.
No, but what if if the breast primary is ER positive? Do you still need to do, because in a resource limited setting, we have to prioritize markers which would really help in patient care.
So what I would suggest is
If ER
the
is positive, would you still want to do GATA3?
Yeah, in that case, definitely if you want to do a staged biomarker profile, we generally go the other way around. First, we prove that it is, we do only, if we would be doing a staged IHC, we would first do a GATA3 first and then do an EPC, because, that is one marker, these are three markers. If it is, GATA3 negative,
Even if GATA3 is
positive,
GATA is positive, you would still want to do ER or negative.
Of course, if it is if GATA3 is positive, definitely ERPR HER2 is needed. If GATA3 is negative, then it is likely to be a metastasis to the breast rather than from the breast, or rather a primary breast. So that is our approach is first to do the GATA3 and CDX2 to prove that this is a breast primary versus not. If it is a breast primary, then we do generally ERPR HER2. But if there's resource constraint and ERPR HER2 is the one available and GATA3 is not available, then of course we can try that. But if the ERPR HER2 turn out to be negative, then you have to go back and do that. That is also, I want to raise a point that definitely GATA3 and CDX2 will be required if it turns out to be triple negative in the IHC and not to be taken as a triple negative breast cancer.
And sorry, madam, I think I lost track because the Zoom was not working for a couple of minutes. Shalaka here.
Yes, ma'am.
So
Yeah, we lost you in between.
I just want to know if Ayushi, would there be any role of TRPS1? Because would that be more specific?
So TRPS1 is not very commonly and available everywhere, Shalaka. That is why I'm not mentioning that. It is not available. If there was TRPS, of course, it is a second confirmatory breast marker because GATA3 once in a while you can see focally in the
Negative.
stomach also. And but other than that, this is not routinely available everywhere in India. So that is why we can, if we go stepwise and use a resource constraint setting, we would do GATA3 CDX2 would be good combined with ERPR HER2. But if you want to stage it, we would put in TMH, you would put GATA3 CDX2 first. And if GATA3 is positive, then we go ahead with EPC rather than the other way around.
Right. The other thing was, madam, I missed, but in the metastatic workup, is stomach and breast the only site, or are there more?
So it is basically there are some nodes, but they are all loco-regional for stomach and breast. So stomach
Right.
looks like stage 1 and breast is T2, N2.
Right. So, ma'am, actually, we have, matlab in the recurrent setting, not in the upfront ad presentation metastatic to stomach setting, but I've seen 2 or 3 such cases over a few years where the GI team has gone ahead and even done a distal gastrectomy for metastasis to the stomach, which did initially look like a stomach ulcer. And when the biopsy was done, it was proven that it is coming from the breast.
Yes.
And since the PET was negative for everything else, we ended up doing a distal gastrectomy also. But after all the systemic chemotherapy first, so we won't upfront operate. But this is, somehow it's a grade 2 tumor. So I wonder if your systemic chemotherapy would largely benefit.
So actually, Shalaka, the report in his pathology report details, it mentions it is 2 + 2 + 3. And mitotic
It's a high
activity given is
mitosis.
18 to 20 per 10. Actually,
It's
that
high.
is also a reason while I'm considering metastasis to the breast, because 2 + 2 + 3 also does not kind of correlate very well with the grade 2 breast tumor.
Acha, you are thinking it's CS stomach going to the breast.
Yeah.
Which is possible, but rare.
Possible,
Yeah,
yeah.
it is rare, yes, but it's possible.
Yeah, in that
But
case,
it
I
is,
guess
but it is
the
mitotically
GI,
active, yes.
so the GI tumors going to breast is slightly unlikely, isn't it, than the
That
other
is
way?
what I'm saying. It is the more common is the reverse, breast going to GI. But since there is nothing being done in the breast, I thought that it should be ruled out since it is synchronous. And the way the morphology is described, 2 + 2 + 3, which is odd, without any DCIS in the breast.
I agree.
Yeah, so the first thing will be, I guess, on immunohistochemistry to get a complete analysis, because the ball is in the pathologist's court to begin with. And when they tell us the primary tissue of origin with all their immunohistochemical gimmicks, then we can discuss what else to do now. Because if these are the only site, maybe we can treat curatively, right, Bhavna ma'am? I mean,
yes, absolutely. We should treat both with curative intent, and even if not curative, I mean, if it's stomach going to breast, even then it's oligometastatic. We should give systemic treatment first and then restage and then take forward for surgery.
So if we assume that this is breast going to stomach, which is more common a situation, and even prognostically it is better.
Shalaka, they have ruled that out. They have done the markers in the stomach biopsy, not in the breast, but they have done markers for ruling out breast mets in the stomach, that they have done GATA3 and ER and HER2 negative.
So my
But GATA3 can be negative and TRPS can be positive. It can still be breast, right?
Yes.
Yes. My strong feeling is this is 2 synchronous primaries.
2 synchronous, possible.
And then, we do ERPR HER2 would be my preference in breast, because that would define the treatment. And if ER and PR and HER2 is positive or whatever, then we treat it as 2 separate primaries. And if they are negative, then we do the GATA3. Then we do, we don't need to do it. We know that it's coming from the stomach.
Yeah, I would agree with that.
Treat with, stomach type chemotherapy like FLOT or something, rather than AC taxane.
Yeah. I have one patient right now, I just saw 2 days back, who was being treated for a CA colon. And then on just a CT scan and a metastatic workup, the breast was the innocent bystander. So we just started treating her for CA breast with hormonal therapy, and Vikas is currently giving her FLOT kind of chemotherapy, I guess, something like that. So
FLOT will work in breast as well, very nicely.
Yeah, it works. So he said that 5FU and all those things will work. So I'm giving her NHT, not operating right now, and along with the chemo, it's a adjuvant chemo that's going on. So the point here is whether, I think upfront surgery may be an okay option. If it,
yes,
if
I actually said that, doing upfront surgery is, but I would still get, you would want the ERPR HER2 on the breast. And if it is a breast primary, it's heavy node positive. you would want to give neoadjuvant chemotherapy, but then you have the concern that stage 1 stomach cancer should not become inoperable. So again, all these pros and cons, doing upfront surgery is also not wrong,
Yeah.
especially if it's ER/PR and positive and HER2 negative.
Right. Yeah, because then the NACT is not going to work very
May
well
not
on the
work as
ER/PR
well.
positive.
Yes,
Yeah.
yes.
And then you're delaying the treatment for CS stomach. So
Yes,
I guess
absolutely.
that would be a fair. How old is this lady? Sorry, I didn't give any,
57.
Young lady, young, 57.
37.
57.
57. Okay.
Yeah.
So because I was just thinking whether she would want conservation or mastectomy, but I guess that would depend upon what she wants and the mammographic picture.
Yes.
But that one can discuss with her. The surgeons there can discuss with her regarding what she wants. Both would be okay if the mammography is amenable to that.
Dr. Haria, you have any points to add here?
Can I see the map? Do we have a mammo picture here?
Ma'am, picture here. Show it.
The report is there, Purvi, I think.
Yeah, report is there. PET
Yeah,
CT,
so
we
there-
have the DICOM.
The 2x2, is that the mammo picture?
Ultrasound.
And only
Yeah.
thing is this is
Ultrasound.
Ultrasound. All
That's
right.
ultrasound.
yeah,
Mammo is not there.
mammo is
No.
not there.
Yeah, mammo is not there. It's FDG PET CT.
So do we have mammography there routinely being done or?
Yeah.
Yes, right. Yeah. So it's just that for planning surgery for the breast, you would require a mammographic assessment because ultrasound wouldn't be adequate. PET, of course, is good enough for actually pointing out the disease, but PET again wouldn't be adequate. So we consider today mammography as the basic minimum imaging requirement for planning breast surgery, especially if the patient is keen on conservation. If she's not keen on conservation, then I guess we don't need it for mastectomy because I don't expect anything in the contralateral breast and that wouldn't determine her outcome as such. So if you're operating on the breast and if she's keen on conservation, then we would need a mammography before. If she's okay with a mastectomy and gastrectomy, that kind of situation, if we are in where both surgeries have to be done simultaneously, then she may choose to have just a mastectomy, which may be easier for her. Because considering the nodal burden in the axilla, unlikely we'll be able to save radiation. So even if it's a mastectomy, she will require radiation. So in that case, doing a breast conservation for a small primary along with, okay, this is a good picture. Yeah, it shows the inner quadrant mass there quite well. Purvi, see that?
Yes. So if you can scroll, this is upper inner quadrant, just the mass, probably some skin thickening, not moving.
And we can see the axillary nodes also on this cross-sectional imaging.
Can you go up?
Dr. Haria, you are not audible. Dr. Haria, your voice is breaking. Hello?
Is it better now? Hello?
Yeah, it's slightly better.
It's better. Yeah.
Okay. Yeah. Just so I don't see any obvious, peritoneal omental stranding or anything which is down in the CT that is visible. Can you slightly zoom the image? Zoom it.
Zoom.
Yeah. Better. Yeah.
So sometimes, we have seen lobular CAs having such kind of presentation. And in one of the distal gastrectomies that we did, actually, it was a serosal deposit of a lobular CA.
Yes. So lobular can be metastasis at unusual sites other than GI and even neurometastasis and unusual appearance on imaging as well. Here there is no, so this is a plain scan and I don't see any, there is a thickening, lesser curvature of the stomach and pylorus area, but and some stranding in the over there, liver disc. There was no PET uptake in the even the images, the report that was mentioned before. Liver lesion didn't show any uptake. Can you go up? I want to see axilla and the breast lesion as well. Yeah, yeah. Yeah. So this is around 2 by 2 centimeter, maybe 2 by 3 centimeter size lesion. The breast is not very dense. Doing mammography here will be, it is must. Sometimes the microcalcifications, TCI's microcalcifications are not visible on any of this cross-sectional imaging like CT scan or PET CT, and they might not even show pickup. They will only be seen as a microcals on mammography. So, considering with this thing that there is no other calcification seen on mammography. I think this is from where the lesion start. Axilla is not covered in this PET images. This is the first image. Yeah, so
Our first
breast
step
lesion.
would be to, yeah, Purvi.
Yeah.
So I can't see the entire area. It starts from the level of the scan.
We don't have it. I think this much only we have, Doctor.
Okay.
Dr. Duncan, Dr. Navjyoti, Dr. Santosh, Dr. Satya, do we have any questions from you?
Yeah. Good afternoon, Bhavna ma'am.
Hi, good afternoon.
Hi, ma'am. So I just like to add a few more information actually. For this patient, the breast biopsy was done outside of our institute, and stomach biopsy was done here. And so we could put IHC, gutter 3 and HER2 on the stomach, and both came out negative. But for the breast, actually, the outside report also had an addendum that HER2 was positive.
Okay.
Other than that, there was no further information, and we couldn't retrieve the block from that outside lab.
Okay.
So it was done in a very remote area. I don't know, they did only the HER2. So this is the only information we had.
So did you repeat the biopsy, breast biopsy?
Yeah, we actually were requested the patient for a repeat biopsy, but actually she refused.
So in such situation, even if we go for upfront surgery, it's not wrong.
Yeah.
But ideally, she would benefit from neoadjuvant chemotherapy and HER2 therapy because she's HER2 positive. But again, you don't know the quality of the report if it's done in a remote area, what the pathology is. And but as Dr. Shalaka said, If she
Yeah.
wants to undergo breast conserving surgery, then you would give a broad spectrum type of chemotherapy, which would work both in stomach and breast. And
Okay.
especially if BCS was not feasible right away.
Okay.
Yeah. So I think patient choice is very, very important here. And the discussion between breast conserving surgery and mastectomy in a curative cancer is really, really important.
Yeah. Yes, ma'am. So,
Are you doing ERPR HER2 in Dibrugarh on site?
yeah, we do have, ma'am.
Very good, very good.
Yeah. So, ma'am, since we have a report of HER2, I mean, how much reliable it is, we are not sure, but should we go by that report and give her some anti-HER2 therapy just to be safe, to be on the safer side?
So again, I would see ERPR is also very important, and HER2 treatment is quite expensive. And
Yeah.
when you don't know the quality of the test and the pathology, like Dr. Tabassum said, I would convince the patient to have a biopsy, because
Yeah.
this has a big implication, and repeat the biopsy locally, and you will get the pathology within 2 days, 2 to 3
Yeah.
days maximum. And this will guide her treatment as well. What if it turns out to be HER2 negative?
Yeah.
And especially if you don't rely on the report, we see that a lot in Chhattisgarh. Patient has been labeled as ER negative, which is so important, and we do the test and find out the patient is ER 8 out of 8. So
Yeah.
all of this is really, really important. If you don't know the lab, you must repeat the test in which has a good external quality assurance.
Yeah.
Dr. Tabassum, you have your hand up.
Thanks, boss.
Yeah, so it's not only for HER2 in this case, maybe grade and ERPR also.
ERPR
the
also,
extent of
yes.
staining can also change depending on, I mean, the quality of biopsy and the processes, pathology processes. So I think it would be very important to convince the patient to undergo a biopsy,
Yeah.
repeat biopsy.
Yes.
We are
Thank you.
planning upfront surgery,
Yeah.
then you can always do the ERPR.
So for
Yes, exactly. I mean, if the patient is okay to undergo, I mean, it depends on her cup size as well. So if she's BCS doable now, otherwise go ahead with upfront surgery based on discussions. If she definitely completely declines, because she has 2 curative primaries,
Yeah.
or oligometastatic from stomach, either way. So you can proceed with surgery as well.
Yes, Dr. Mittal, you have something to ask?
Yeah, I
Even
want
if
to
she's
ask
HER2
the surgeon, what are the points against doing the primary surgery for both the malignancies?
So we are recommending primary surgery for both malignancies only, because even if she's HER2 positive, there is as such, I mean, yes, it will be good to give her some anti-HER2 therapy, but it's not absolutely necessary that it has to be done before surgery.
Tilaka, your voice is a bit low.
Dr. Joshi, your voice is not audible. It's very low.
It's just N2 disease. That's what I don't.
Because I prefer primary surgery for this patient. My preference
No,
would be
primary surgery should only be offered if she declines a biopsy. And in a center of excellence, she should have some neoadjuvant chemotherapy, especially if HER2 positivity is confirmed.
That's only what plot.
Madam, I'm okay to have primary surgery first, even if
Yeah,
she's HER2
absolutely.
positive.
But
So
if
doctor,
BCS is not doable and she desires BCS, there are a lot of complexities here.
then
And
it is a different matter.
HER2 positivity, then one should offer her that option at least, and then she can decline.
Okay, shall we go to the next case, please? If there are no more questions.
Sure, let's go ahead.
Yeah.
Yeah.
This was a good case for discussion.
Yes, it
Thank
was.
you, ma'am.
It got everybody involved.
Yeah.
Dr. Naga, you can increase the font by 120.
Yes, sir. Yes, sir. We are doing that.
Good. This is good. Yes.
Yeah. This is good.
So that is why MDT discussion is so important, because, you get to know the differences in opinion as well. And it's important to differ in opinions and come to a consensus at the end of the MDT.
Yeah, I mean, before Ayushi raised her points, we were all thinking, I mean, that these are all separate two primaries.
Absolutely. Absolutely.
No, ma'am, there are a few cases wherein we got referred from the DCC. Like they are choosing cases which are actually making the decision very complex. So especially this multiple site metastasis or primary versus secondary, that confusion is there. I think we have a couple of cases along the similar lines wherein we had consulted TMC NCG experts and we went back with an expert opinion. And then we had a discussion in the virtual tumor board where the doctors reviewed the opinion and they had some questions and we went back. So this process is actually helping a lot. And MDT review is important, especially in these kind of cases. Thank you for pointing it out. Yeah, next.
Our next case is 63-year-old female who is a known hypothyroid and type 2 diabetes, also has insomnia, presented with complaints of right breast lump in April 2023. Her mammogram showed right breast superior lateral quadrant lesion, spiculated margins, stromal architectural distortion, skin fold thickening, bilateral axillary lymph node, largest in the right axilla, BIRAD score is 4. Fine needle aspiration cytology of the right breast on 22nd April 2023 showed ductal carcinoma. Metastatic workup prior to surgery was not available. Patient underwent curative definitive upfront right modified radical mastectomy along with axillary lymph node dissection on April 26, 2023. Pathological tumor size was 1.6 into 1.5 into 1.5 centimeter. Tumor focality was unifocal. Final surgical margins were negative. Number of pathological axillary lymph nodes positive out of 33 lymph nodes resected were 4. Pathologically largest axillary lymph node size was more than 0.2 centimeter. No extranodal extension. Malignant disease was invasive ductal carcinoma. Cancer grade was 2. Ductal carcinoma in situ was noted. Nipple DCIS was no. Lobular carcinoma in situ was no. Mitotic rate of 2. Necrosis was noted. Lymphovascular invasion was positive. Dermal lymphovascular invasion was negative. Skin involvement was not seen. Skeletal muscle involvement was also not seen. ER positive, PR positive, HER2 new negative. Pathological anatomic TNM staging is stage 3A, PT1C, N2A, MX. Pathological prognostic TNM staging was stage 2A, T1C, N2A, MX. ER positive, PR positive, HER2 new negative with grade 2. CT chest on May 17th, 2023 showed no evidence of malignancy. Radiological note said no significant abnormality detected in lung parenchyma. Ill-defined mild peripherally enhancing hyperattenuating areas along the right anterior chest, deep to the right pectoralis muscle, post-operative changes. CT abdomen pelvis on May 17th showed 3.6 into 3.3 into 3 centimeter right ovarian cystic lesion, bulky ovary, no evidence of malignancy elsewhere. Patient was started on curative definitive adjuvant chemotherapy with doxorubicin cyclophosphamide from May 22nd, 2023 to July 26, 2023. Post that, she was started on adjuvant radiation therapy from August 16th, 2023 to September 8th, 2023. A sandwich chemotherapy was planned because of poor tolerance to chemotherapy. Post-radiation, she received 4 cycles of paclitaxel from September 26th to December 5th, 2023. Patient complained of grade 3 neuropathy. And her second cycle was delayed by 1 week due to grade 3 neuropathy. For post-adjuvant paclitaxel, she was started on letrozole 2.5 from December 2023 and currently ongoing. Complete administered protocol detail not available. Patient had a complaint of frequent anemia, insomnia, dyspepsia, and body aches. FDG PET-CT on April 20th, 2024 showed right pectoral region post-operative changes. FDG with pectoral muscle residual inflammation, 3.4 into 3.3 into 3.2 centimeter right adnexal lesion with an SUV of 12, abutment infiltration of adjacent bowel loops, no evidence of malignancy elsewhere. Radiology note, no definitive evidence any anatomical or metabolic anomaly in the operated bed of right breast to suspect residual or recurrent disease, a hypermetabolic lesion in right adnexal lesion, probability of mitotic involvement. Patient underwent a right salpingo-oophorectomy on May 15th, 2024. Pathology note, ovary and fallopian tube are positive for malignancy. Differential diagnosis include undifferentiated carcinoma and metastatic carcinomatous deposits, possibly from breast. IHC was negative for WT1. A slide block review of right salpingo-oophorectomy sample was done on June 11, 2024, which showed serous carcinoma. Pathology note involved by a high-grade adenocarcinoma of Mullerian origin. IHC was positive for PAX8 diffuse and P53 diffuse. IHC was negative for ER, GATA3, NAPSIN, P16, and WT1. A slide block review was done at a reference lab. Query FIGO stage query 4A. Functional ECOG score is 1. General condition, able to do activities of daily living without assistance. Symptoms include right arm swelling and occasional pain, unable to lift the right arm fully, waist pain in right side of the body, and cough. Patient has resource constraint. Treating oncologist has planned for PDL1 and HRD testing. Navya questions, given slide block review is suggestive of endometrial origin, further management of the disease, role of continuing the ongoing hormone therapy with letrozole, and role of additional diagnostic test with endometrial aspiration versus alternative.
Sorry, I'm just going to ask for a summary. She was on treatment for CA breast, right?
Dr. Tabassum Vatsadwala, can you start the discussion?
We can't hear you, Shalaga.
She wants a summary, Dr. Tabassum. If you could just do a summary of the case.
A breast treated earlier. Did she finish her treatment or was she on treatment while she
Dr.
developed
Sakala is not audible.
No, actually, Shalaka, she didn't finish
Yeah.
treatment between in adjuvant ke baad hi radiation de mil gaya. And then she completed her chemo after radiation, adjuvant chemo ke baad.
Yeah,
And
sandwich
that
was
also
given.
she did not tolerate well because of tolerability issues. So this is a lady who's not very tolerant to chemotherapy.
She's
Right,
on
so she's
hormone therapy. She's on
She's
hormone.
on endocrine therapy, letrozole, and she has two primaries, basically breast and endometrium. Is that
Endometrium.
correct?
Yes.
Yeah.
endometrium
So
is an adnexal lesion, isn't it?
Yeah.
It was an adnexal lesion and it was a salpingo-oophorectomy, I heard.
Yeah, actually, Shalaka patient underwent a salpingo-oophorectomy in which they proved they did a lot of markers for identifying whether morphologically does it seem to be like ovarian carcinoma or is it endometrioid type of ovarian carcinoma or is it possibly of endometrial origin. Finally, after doing a lot of panel of markers, they have said basically it's a high-grade adenocarcinoma of Mullerian origin, of which possibly it's a serous adenocarcinoma of endometrial origin, with a lot of panel of markers that have been done. So it's a lot of, because endometrium and versus ovary is quite a, this marker, that marker kind of positivity situation. So in that, they have basically the heading is high-grade adenocarcinoma Mullerian origin. That much they have confirmed that it is from Mullerian origin. But of that, with the panel of markers positivity, the way it has come, they have said that it is possibly a serous adenocarcinoma of endometrial origin.
but uterus is still in situ, is it?
Exactly. It is just an ovary.
Yes.
Only BSO has been
Exactly,
done.
uterus.
Because it's a oophorectomy, it's one side, it's
unilateral
not even
oophorectomy has been
bilateral.
done.
It's a unilateral salpingo-oophorectomy.
Yes.
So would
Yeah,
you
right
be
side.
able to pick that? Would you be able to pick an endometrial CA or is it an endometrioid type of ovarian CA?
Yeah, that is what they have not called it an endometrioid adenocarcinoma. They have called it a serous adenocarcinoma. But the way the markers have come, it could be possibly of endometrial origin. That might be tumor left behind in the endometrium, which is extending to the ovary.
Is
So
there
the
a need
MRI
to
pelvis has been done here?
Just check.
It's only
No,
checked.
ma'am.
MR
Not yet.
pelvis will give.
Should we
Just
go
to
ahead
see
with a
whether
hysterectomy?
she has some endometrial thickening or maybe a TVUS as well. Because then she needs to undergo completion surgery first of all for the uterine primary.
Yeah, that is very important.
Yeah.
PH, BSO, and
So PET
PH,
CT may not pick it up. Maybe MRI or transvaginal ultrasound can, look at the endometrial thickening.
But in either case, if she's got ovarian versus endometrial CA, she would require a TH, a total abdominal hysterectomy and bilateral salpingo-oophorectomy, of which unilateral has been done. So they can do the completion surgery anyway. Now the question is between endometrial and ovarian CA is, would you do pelvic lymph node sampling? So you can probably, since there's a doubt of endometrial CA, can also do pelvic lymph node sampling in this case. And abdominal surgery can be completed that way. And then we can discuss adjuvant for the endometrial CA.
Agree. Yeah. I think she needs completion surgery first.
Yeah, completion surgery. Because also the way the PET CT is reported, it says that there is an adnexal mass which is involving bowel loops, infiltration of adjacent bowel loops and all that. So a complete surgical debulking is necessary irrespective of whether it is CA, endometrium or ovary.
Yeah.
The only thing that differs here, and it is non-metastatic because you have the PET as M0 elsewhere.
Yeah.
So only thing that differs between ovary and endometrium would be to do pelvic lymph node sampling or not. And since if it is infiltrating ovary and it's a higher stage endometrial CA, then I guess a sampling of the bilateral pelvic nodes would be good. And then I guess Bhavna madam, you can tell us about adjuvant after that for endometrial CA. What would that be?
I think it depends on the myometry. If it's endometrium, it depends on the myometrial invasion and all of that. And I think markers like, I don't do gynae cancers, but I attend the MDTs. So P53 MSI testing is another thing that you would do because that defines the prognosis for the patient.
Do we have PET CT images here? That the one that is done?
Anything else from the Dibrugarh team about this patient? Would you be planning for completion surgery here?
Yeah, ma'am. I think that is the best way to go actually.
Yeah.
Must
I
go
think
for
so.
a completion surgery.
Yeah.
So I would like to ask the Dibrugarh team, do you have MSI markers in your hospital, immunohistochemistry?
No, ma'am. No, ma'am.
Not yet? Okay.
Not yet.
You can scroll this images. This is here.
Yeah.
But we can we have tie with TMC Kolkata, so we can do it.
Yeah, because if it turns out to be endometrioid or endometrial, that would be quite helpful to have MSI markers. She's P53 positive mutant type as per the report, but MSI is also very good for currently being done. I think it is routinely done in TMC Kolkata also for the prognosis as well as further therapy planning of CA endometrium.
Yes, ma'am. As per CT scan report, there is no abnormality with the endometrium. Actually, there is no thickness of the endometrium mentioned.
CT scan is
Still, I believe,
only
completion surgery would be quite better. Yeah.
Yes, Dr. Haria, you were saying something?
Yeah, so CT scan is not very accurate to, endometrial thicknesses. Yeah, you either do a transvaginal ultrasound or MRI pelvis. So here, what you're scrolling, I agree, there may not be anything inside the uterus because uterus size is not, it's a normal size uterus. It's not very bulky uterus, where, but that's again not the ideal to see on the CT scan. There are no RP nodes, retroperitoneal nodes, and even the pelvic side node, side wall nodes. Right adnexa, there is, so this was right salpingo oophorectomy, right?
Yes.
Yeah.
It is
Yeah,
right
so this is
salpingo.
pre surgery.
But how was this picked up? Did patient have any symptom, or had we done a PET scan for some other reason?
We do. She was on a hormonal treatment, so after 2 months we did a ultrasonography. Then it got picked up.
PET scan.
Oh, so it was
Then we did a
asymptomatic.
PET scan.
Okay.
Yeah, Dr. Tabassum Vatsadvala, you have anything to add for this case?
No, nothing more. But yes, ultrasound, TVS ultrasound will only give you, this seems to be some early disease in the endometrium, which has, I mean, don't know. So only pre-operatively TVS ultrasound would give some idea about whether it's originating from the endometrium or not.
Yeah, regarding we can differentiate between endometrium versus ovarian high-grade serous. Actually, that is what the panel of markers that have been done, that is what it was targeted towards. So they have done a broad panel of markers to, so basically what is against completely a serous diagnosis is negativity for WT1. So as you can see in the report, so there was WT1 was negative. So with
Negative.
this complicated panel of markers, and it is negative for napsin, which indicates clear cell carcinoma. It is negative for ER, which is for endometrioid. So it is a little bit of complicated panel of markers. Results have come. So that is why they have not called it one type or the other, but they have said that it is basically the broad categories, high-grade adenocarcinoma Mullerian origin, and in that possibly with the pattern of markers that has come, it is a serous adenocarcinoma, possibly of endometrioid origin. So it is not a straightforward diagnosis here. The markers have been done are completely appropriate, but the results are such that it is not a exactly pinpointed that it is of ovarian or endometrioid origin. It is likely to be endometrioid. That is what the marker impression is.
So you mean to say if you do MSI, you will be able to then
No. That is a predictive marker, not for diagnosis.
Okay, so for diagnostic panel, you don't advise anything else to be.
No, the panel is complete. What has been done is complete.
Okay.
So I guess surgery would be the next step here. Is that what we are finalizing?
Yes.
Yes. Now, one thing is keep your questions. So stay there at Navya questions. So we have one question: role of continuing ongoing hormonal therapy. Yes, I would continue the letrozole for CA breast.
Yeah, that should be continued.
Yeah. And role of additional diagnostic tests. Yes, the transvaginal ultrasound might help, but the patient needs completion surgery irrespective of CA ovary or endometrium. So one may proceed with that.
So here I have a question for all the panel members. If the Dibrugarh Cancer Center doctors have any questions, we can discuss that. Otherwise, I will go to the questions that I have.
Yeah.
So my question is now we have seen two cases so far, which is a multidisciplinary review. So I request all the panel members to give their thoughts on one, how this MDT review is giving a more insight into management rather than the individual surgeon or medonc review. And second one is how this in-person MDT review and this virtual review are making a difference. What is the difference you are seeing in a virtual review of this nature, wherein we are presenting in different places and then reviewing the case, and then compared to what you would do in a hospital setup where you do the in-person review?
It saves a lot of time. I mean, if one person is just contemplating what to do, and then we will speak to a surgeon separately, we will speak to the pathologist separately, radiologist. So here in MDT, you have everyone on board. So it saves a lot of time for the patient as well as, I mean, the discomfort of individually speaking to everyone. So that is very important. And also as we putting experts together also gives us a different difference in opinions are there, so that we are thinking in each along each and every aspect of the possibility that is being explored, and then we come down to a consensus so that we are taking informed decision, I would say. I mean, this is a typical example where the IHC panel is not very straightforward result. So, in such cases, then individually we are not very confident how the patient should be treated. But when in an MDT, when we put our minds together, then we come to a consensus that as an MDT we would be then treating this patient on ovarian lines or on endometrial lines.
Okay, ma'am.
So generally speaking, all patients, I think new patients should be discussed in an MDT, and there is enough evidence to show that patients who are discussed in a multidisciplinary team meeting have better outcomes because you have unbiased opinion from all the key specialists. And as far as virtual versus physical is concerned, I think during COVID has taught us that virtual is as good as physical, as long as you can see the scans and be able to show. Very rarely we need, I know Dr. Ayushi said very rarely you need to see the pathology, but sometimes you do need to, especially if you want to, a second opinion on that. But most of us don't have digital pathology. But I think scans one can review online, and absolutely no issues with virtual MDT.
Yeah, but for surgical and at least the loco-regional treatment, I think patient has to be seen. But yeah, reports and all can be reviewed virtually.
I agree. Yeah. So that again, the clinical review, the clinical team who has seen the patient should be there.
Yes.
As long as they can describe things like performance status, which is the most important, I think, and organ function and all of that. Yeah.
Also, ma'am, here I would like to add that with this, the kind of reports and everything is available here in this thing. We are not having to go back and forth. By and large, we have a lot of the reports, the marker, the radiology and workup done. So that is highly appreciable, because otherwise you are most of the time trying to scramble, asking for this thing, that thing, and that is not available.
Yeah.
So if everything is available, it is much easier to come to a consensus and decision.
Yeah, Dr. Joshi, your views on these questions.
No, I agree with most things that are said already. So the thing is, if such a case were in our OPD, I guess the first call I would give would be to the pathologist to understand where is this coming from. So she would get a first call, even if may not physically sit together. I would need her opinion. The second call would go to the radiologist, because then I would ask her, okay, do you see anything in the endometrium? Do you see anything elsewhere? So if everybody is under the same roof, it always helps. But often, in our setting, we cannot sit together at one point of time because we see at least 70 to 75 patients in a day. But the thing is that the crosstalk happens somewhere in the WhatsApp group or somewhere. The run-of-the-mill cases where we know each other's protocols, it may not matter. But the odd cases, difficult cases always get discussed in MDT clinic. So whether it's online or physical may not really matter, as long as, but yeah, like Tabassum said, we would like to. So if you ask me what surgery should be done, and you might have noticed that even on the Navya, when panel, the questions or the opinions come to me, I say a clinical examination is required for perfect surgical opinion. So I cannot tell you what kind of breast conservation surgery, oncoplastic procedure should be done unless we examine the patient. So for that, I would say refer to the closest surgeon. I even provide numbers sometimes if I know somebody in that city. So that kind of more detailed discussion will happen only when we see the patient, especially for breast surgery. I do not give opinions anymore regarding conservation of surgery or mastectomy without having seen the patient as well as the mammography myself. So I don't give opinions on mammography reports anymore because it's incorrect to do that and give opinion without examining. But yes, a surgery should be done versus a chemo should be done. So MDT discussions do help tremendously. And this is great that you are able to put together all this in this manner where all reports are available to us, and even imaging and path and everything is available. So this is commendable that we are able to help somebody from that distance. I hope we are able to, that is.
Yes, ma'am. Thank you so much. Dr. Sahai and Dr. Haria, can you please add your comments?
I've already given my
Okay, fine. Yeah. Okay. Another thing I would like to ask is, like, suppose if in general, many of the hospitals have a policy that they take each new case, like Dr. Sirohi was mentioning, each case to go through the MDT, and then they finalize the treatment or the diagnostic steps or whatever it is for every case, every new case. Like even the simplest case, they do that. Like how it is beneficial to have each case going through an MDT or versus only complex cases going through an MDT. Like, do you see any reason for having such kind
Yes,
of
no,
approach?
if I had only 5 to 10 patients in a day, I would take each case through the MDT. So
Okay.
each oncological case requires multidisciplinary treatment. There is no doubt about that. It is just sometimes we are aware of each other's functions to an extent that I know when my colleague Tabassum would give radiation. And she's also aware when she should refer for surgery. Our medical oncologist is also aware when to refer for surgery. Tumor is not responding. So we have a working knowledge because we interact a lot in our disease management group meetings, etc.
And
But
we
if we
have
have
set protocols also, no, Shalaka,
yes,
for each
yes,
early.
yes.
And so that is why all the protocols are known to everyone. So so that works in our system, that we are not discussing each case.
So, but Tabassum, we need to predefine, like in the NHS, all patients have to mandatorily go through the MDT. So if we are able to, let's say, stage 1 breast cancer or stomach cancer, there is a clear pathway, surgery. So if you, in your institute, I mean, in our institute, we are not able to discuss all patients because, the volume is very high. It's impossible.
Yes.
But, you can define clear pathways.
Yeah,
And
that's
then,
what she said. Protocols are defined. Yes.
Absolutely. So,
Yeah.
So we
NCC
have our
has these,
guidelines.
absolutely.
Yes.
So,
And we also-
Naga, I have to go, but I just wanted to
Okay.
congratulate the Dibrugarh Cancer Center team for doing such an amazing work for patients locally, because, it means, of course, the burden in places like Tata Memorial Hospital is less. And so you've been there for how long?
2 years.
2 years now. So congratulations. And thank you so much for doing what you're doing. And of course, Navya as well, for democratizing, I feel, cancer care in India.
Thank you so much, ma'am. Thank you
ma'am.
for your.
Thank you.
Sorry, I have another meeting to go to. Thank you. Thank you.
Thank you, ma'am. So, any other questions from the participants are welcome. And anything else from Dr. Duncan, Dr. Santosh, and Dr. Satya?
No, thank you.
Thank you.
It was a
nice
very nice interactive discussion. When we learned a lot, and
Thank you. Thank you so
Thank
much.
you.
thank you to all.
Thank you.
So I thank all the participants for joining us, and all the panel members for joining on time and helping us out to have a fruitful discussion, giving us very good insight about the case. Like when we selected these cases, we never really had an insight that we get to hear so much about the diagnostics, and so many things will be discussed in this actually. We thought that this is already gone through an expert review, and we have the entire details, but still there is so much to learn and so much to explore. I think that's the importance of MDT. That's where we, everybody can contribute, and we get to know a lot of other things, and the patient will get the ultimate benefit. So I thank everyone, and thank you so much for your valuable time. Thank you so much.
Thank you.
Thank you.
Yeah.
Bye.